Going to get started, and I hope that I'm on Zoom, though I can't see any Zoom comments or questions unless someone else can in here. I'm gonna log into Zoom actually. Okay, I'm on Zoom on my phone. So can y'all give a on Zoom? Can y'all hear me okay and see the screen? Okay, yes, perfect. All right, well, welcome everybody. This is a much better showing than last week when I was initially scheduled, but everyone was at AAN. Like we had like 2 or 3 people total. So moved it to this week. I'm Chelsea Sugars. I'm one of the neuromuscular specialists here at Erlanger. And the focus for today's grand rounds is going to be discussing new and emerging treatments for myasthenia gravis. I know we have pizza coming, so I'm going to do like the first part of the talk. Then we're going to take a pizza break so people can get food, and then we'll do the rest. I think I have like a good transition point. So just so those on Zoom know, there will be a pause at some point soon. Some disclosures, I have served on advisory boards for argenx and UCB. I've been a speaker for Alexion, who's also helping to facilitate some of our abstract posters and publications for some cases. I'm a sub-investigator on our myasthenia gravis registry with Alexion and also on another trial with argenx, which is actually part of this talk that we'll be talking about. The objectives for this talk are to review the clinical manifestations of myasthenia, understand the pathogenesis of myasthenia, to discuss new and emerging immunotherapy options, particularly the role for complement inhibitors and FCRN blockers, and to give an update on clinical research studies that are going to be coming here to Erlanger. So how common is myasthenia? I feel like us in neurology see it often, and myself and Dr. Alpers as neuromuscular specialists, this is probably one of the most common diseases we treat, but in general, it's not that common. The incidence ranges in the literature, but most recent data, this is pulled from Muscle and Nerve article that was published beginning of the year. Incidence in the US is about 3.1 per 100,000. Prevalence is about 37 per 100,000. In general, they've been both increasing over time. That's partly because of better recognition of the disease, better treatments. We have the aging population. So a lot of that has contributed to changes in incidence of prevalence over time. As a perspective, I think per Google, our population in the Chattanooga and greater area is about 500,000. So we probably have 150 to 200 myasthenics in this greater area. I think we have some currently in the hospital. Dr. Alpers and I see many of these patients. And so I think many of y'all get exposure to these patients, so hopefully this talk is helpful. Some of you may be familiar, but there's a bimodal distribution to myasthenia for age and sex. This is data in the table from Muscle and Nerve article published earlier this year that for patients diagnosed before the age of 50, it's more commonly diagnosed in females compared to males, but after the age of 50, it's more commonly diagnosed in males compared to females. But overall, as people get older, it's more common. Myasthenia gravis has been around a long time. It was Thomas Willis is a British physician who was first described myasthenia back in the 1600s. Better descriptions were developed over time, the 1800s, and then getting into the 1900s, we started to develop treatments for myasthenia and the role for thymectomy in patients. The hypothesis for autoimmune pathogenesis came out in the 1960s. 1980s, plasma exchange and IVIG became available. And then more recently, a lot of other biologic drugs and immunotherapies have been available. And so been around a long time, but really it's only in the past few decades, and really in the last decade, we've had significant expansion of drugs for myasthenia. So there are many, manifestations of myasthenia. Some patients may just be ocular, which means they just have ptosis, diplopia, and they won't have involvement of other muscle groups that'll be noticeable. Other patients would be categorized as generalized myasthenia, which can have a variable combination of ocular, bulbar, limb, or respiratory weakness. We also classify myasthenia based on their antibody status. We have acetylcholine receptor, muscle-specific kinase or MuSK antibodies, and then we also have what we call seronegative, which I'll get into that a little bit detail, but that's the general classification you'll see for most myasthenics. This diagram to the right is, we're going to see a lot of pictures of the neuromuscular junction, but that's pretty much what this is over here. At the top is your presynaptic membrane with the nerve. At the bottom is your muscle membrane or postsynaptic membrane. And you can see all these different proteins that are involved in the neuromuscular postsynaptic membrane, and including the acetylcholine receptor, MuSK, and others like including LRP4, which I'll get into more, but there's a lot of proteins and large complexes at the postsynaptic neuromuscular junction. This is pulled from Netter's. I'm sure y'all had this atlas available maybe back in med school. The far left picture, the pink areas, which are around the eyes and the mouth or lower face, this is where nearly all of your myasthenics will have weakness. In some patients, this may be the only place that you notice weakness on their exam. And so a key clinical or skill to have would be checking eye closure strength, even like lower facial weakness with cheek puff, see if they can extrude air when you put pressure against like a cheek puff. They may have tongue, more ocular bulbar weakness. Less commonly, they'll have weakness in the extremities, proximally or in their hands, or proximal lower extremities. Less commonly, more diffuse weakness, respiratory weakness. And then these are more pictures of, I'm sure you've seen many patients with ptosis. We aren't doing a trophonium test anymore, but you could do an ice pack test at the bedside in the hospital. I've done it East a few times, that you have clinical ptosis, you put an ice pack, and that would lead to resolution of ptosis as a bedside quick exam you could do. Checking for neck strength with neck flexion and extension weakness. And then the bottom picture, I think, is just the clinical aspect that many patients feel better earlier in the day, and there's a component of fatigability later in the day or with repeated movements. We classify myasthenia also based on the MGFA scale, and I just threw it here just so you'll see it, because some of these medicines are really only approved for classes 2A, classes 2 to 4, because that's what was used in the clinical trials. If a patient only has ocular manifestations, they're classified as MGFA 1. If they have mild, moderate, or severe generalized symptoms, they're classified into classes 2, 3, and 4, respectively. There's subclasses of 2A and 2B, these based on more axial versus bulbar involvement. So if you see that in our notes or in trials about what's appropriate to use each drug, that's just a brief reference point. And then if a patient is intubated in ICU, they're a class 5. There's an association with myasthenia with other autoimmune conditions, including autoimmune thyroid disease, even stiff person syndrome, NMO, and others as well. And there's the role of some of these medicines we're going to talk about are also approved or being studied in these other indications as well. Is pizza here? No? Okay. I'm gonna keep going then, and someone holler if there's pizza and we'll take a break. So how does myasthenia occur? Okay, we'll take a break. Everyone please get pizza.
This was on the first circle of bank, but he also resuscitated a woman.
I did not know that.
She arrived from that section of his lab. Brought her back to life, and she had a family.
That's cool. Yeah, I mean, it's like a man of many talents or well-documented observations.
Like a still one, most likely. And so they thought about like executing her at the end. They decided I thought about it. The church was like, she's probably innocent. God's very private. Literally 3 they were criminals to be sent off to be dissected as like a second punishment. She showed up. So yeah, it's rough times. No.
I feel like I'm like craving pizza now. Like it's
I know, right? You said it so many times, now your brain's like, where is it?
Oh yeah, I'll do that next. Oh sure, I'll talk. I'll say that. I'll let people get in. I'll see what's left when I'm done. But thank you. There's also food upstairs, so I can get some if I miss out on the pizza.
That's the only
He
treatment.
doesn't have myself.
Oh, that's the only treatment I need for myasthenia, so take
It also
pictures.
works for that.
Okay.
The board.
Plastic surgeons have, you know, facial tape, so. People that are. I mean, well, excellent. No,
He's still, last time I saw him, that is a whole file. He's like, oh, my son, that was like, I'm sure I would. Because you have my study, and he's like, no, she's not, it's double, he's like, yeah. It's like, everyone's like, I don't have my study. Okay, good, good for you. Have you seen her back?
all the symptoms, but no.
Okay, I think there was anybody positive.
Yeah. Like, I'll take this medicine, but I don't know. That would be great. I would be okay with that. Good thing you're taking it for your process.
But he doesn't have to. He got followed by that.
Good for you.
Yeah.
I know they weren't there. Are they comfortable?
They're comfortable. It's just some problem here. Like European people. Okay, no. Yeah, bad person.
And also, like, if it's leather, it'll start.
All right, I think everyone has gotten their pizza who wanted it. It's trickling in. I had a question about how to do an ice pack test. So I'll do that briefly.
For like some of the shoots later on. What's that? Later on. Yeah. But there's
So with an ice pack test,
Sorry.
yeah, sorry, I got to talk. I'll give a grand rounds. This is where you would use in patients who actually have ptosis. So if they don't have any ptosis, you can't do an ice pack test because you're going to look at the improvement in ptosis with an ice pack test. So if they have ptosis, and usually I'd grade ptosis based on how much of the pupil is covered. Let's say it's like covering half their pupil. That's your like baseline. Get a pack of ice, throw it on that eye or both eyes for 5 minutes, take it off, and then have them open their eyes and see where their eyelids are and see if their ptosis has improved. And so this works because cold slows down the mechanism of acetylcholinesterase in the neuromuscular junction. So the acetylcholine lasts longer and the muscles work better because there's more acetylcholine sitting around. This is also why like patients do better in wintertime with myasthenia because cold helps to slow down the breakdown of acetylcholine by acetylcholinesterase. And in the heat, it speeds it up. So patients, you may see more flares or exacerbations during the summertime. Patients feel more fatigued in the summer in the heat. It all has to do with acetylcholinesterase function in the junction. So more about pathogenesis of myasthenia, and I'm breaking this down more based on patients' antibody type because the mechanism or the pathology is a little different. which is also important for understanding how different classes of drugs work for myasthenia. Most patients have positive acetylcholine receptor antibodies, like 80% of patients, and these are IgG1 and IgG3 subclasses. And how the acetylcholine receptor antibodies work to cause myasthenia is in a few different ways. That's what this picture to the left is. The first, which is particularly, unique compared to some other antibody types, is how it works on the complement system. And basically, this top left picture, you have a picture of the neuromuscular junction. At the top is their nerve and presynaptic membrane, which would release acetylcholine into the neuromuscular junction. The bottom part is the muscle membrane, which you have these folds, which increases surface area for acetylcholine receptors. And so that little, I don't know if this works. No. I don't have a little laser, but the little red icon that says IgG, little antibody icon, it blocks the acetylcholine receptor, which is the blue, and that then leads to promotion of cross-linking of the C1 complex and complement cascade, which is this middle picture, which induces the membrane attack complex, which then leads to destruction of the acetylcholine receptors or destruction of the postsynaptic membrane. And so that's one mechanism, is through this complement cascade at the top. The antibodies, when they bind to the receptors in picture B, it also leads to those receptors being internalized and broken down. And in picture C, it also just leads, when the receptors are blocked, then the acetylcholine can't bind. So just like physical blocking. And so that's, multiple models of how the acetylcholine receptor antibodies cause myasthenia and then weakness. For other antibody types like MuSK, or muscle-specific kinase, this is present in about 10% of our patients, but it's a different subclass of IgG4, which does not involve the complement system. So for these particular patients, the complement inhibitor medications would not apply because there's no pathology there with the complement cascade system. And normally, just as reference point, the MuSK protein is what promotes clustering of acetylcholine receptors, so that there's more receptors on the membrane, you get more signaling, people are stronger, and then if it gets blocked, you have less, it leads to less receptors, and so you have less transmission at the neuromuscular junction. And then about 10% of patients are in this category we would consider double seronegative, which means they're just negative for acetylcholine receptor and negative for MuSK antibodies. But these patients really have antibodies to other stuff. We just can't routinely test it. So actually about half of these will have low affinity acetylcholine receptor antibodies that can be detected on specialized cell-based immunofluorescent assays. And so since they're acetylcholine receptor, they can have activation of the complement system. There's other antibodies, including LRP4, which is an IgG1 subclass. There's others, including cortactin. And here's a diagram of bottom right of the acetylcholine receptor and how it connects to many other proteins, including MuSK and LRP4. This all, leads to promotion and maintenance of the acetylcholine receptors. So you can have antibodies to nearly any of this, but we just don't test it on a routine basis. This is more research models. And here's another blown up diagram of all these proteins in the neuromuscular junction, kind of repetition of what we saw before, that you can have antibody binding to any of these sites, which most of the time leads to degradation of the acetylcholine receptor and decrease in neuromuscular transmission. And in a normal person who does not have myasthenia, an action potential would lead to release of acetylcholine from the presynaptic nerve terminal, which would then bind those little purple dots to the blue acetylcholine receptors, which then leads to sodium influx, depolarization, and muscle contraction. So this is what a normal pathway is, and these are all the ways it can get blocked, basically. And there are a lot of treatments that have been around for decades for myasthenia, and a lot of these are probably very familiar with, and this is what was traditionally used until some of these newer agents came out. We have acetylcholinesterase inhibitors like protastigmine. This is not particularly an immunotherapy, but more of a symptomatic treatment. It's a quick onset of like 30 minutes. It can last 3 to 4 hours, then it's out of your system. It's fairly well tolerated. Some patients respond pretty well to it. Some patients do not, especially the ocular patients may have no response. It's variable. Corticosteroids, specifically prednisone, have a fairly quick onset of action within a few weeks if adequately dosed. But long-term steroids can have side effects, including osteoporosis, weight gain, hyperglycemia. And so high doses long-term are really not ideal for most of our patients. We have steroid-sparing immunosuppressant therapies. Probably most commonly used are azathioprine, mycophenolate. Sometimes we use rituximab, especially in MuSK-positive patients. But these take longer to have an onset, particularly azathioprine can be 6 to 12 months or longer to really have a peak effect. So they have their role, but longer onset of action. They have other adverse effects. It can cause cytopenias, effects on liver function and others, and they need other types of lab monitoring. And patients who are in myasthenic crisis or patients who are refractory to traditional treatments, we may use IVIG or plasmapheresis. And then in other selected patients, particularly those who are young and acetylcholine receptor positive, there's a role for thymectomy for long-term control. And so that's, background of a lot of our patients are still on a lot of these treatments. But we also have a lot of other new and emerging treatments coming for myasthenia, which is what we're going to get into. The main groups are neonatal FC receptor blockers and complement inhibitors. And these are the 6 that are currently approved by the FDA. We have Vyvgart or efgartigimod, which is an IV form. Vyvgart Hytrulo is subcutaneous. Rystiggo or Rosanolixizumab is subcutaneous. Of the complement inhibitors, Ultomiris or Eculizumab has been on the market the longest. It is IV. Ultomiris and Zilbrysq were most recently approved. So what are the neonatal FC receptor blockers and how do they work? The neonatal FC receptor is expressed on endothelial and myeloid cells, and it promotes recycling of antibody molecules, specifically IgG molecules. And when you block that, you're leading to depletion of IgG in the system. So it kind of maybe reminds you of like plasma exchange or getting rid of immunoglobulins, but this is more selective to IgG, can lead to up to about a 70% reduction in IgG levels from baseline. It does not affect IgA and IgM and other levels like Plex would. But these are newer medicines that do not have long-term studies yet. And currently there's just 3 that are FDA approved. This is the left diagram is how the neonatal FC receptor normally works. And so we have these antibodies, which is this blue, black icon on the top left. They're taken in by the endothelial cells, and some of them will bind to this orange neonatal FC receptor, and that saves them so they can be recycled. If they don't bind to that receptor, they get broken down by the lysosomes. They're cleared from the body. How this group of FCRN blockers works is it binds to that neonatal FC receptor so that nothing can get recycled, basically. Leads to breakdown of all these IgG molecules. And efgartigimod or Vyvgart and Vyvgart Hytrulo, this is the first ones I'll go over. They're FC fragment molecules. The Vyvgart, IV Vyvgart was the first in class. It is dosed once a week for 4 weeks, IV. The Vyvgart Hytrulo is a subcutaneous form that's dosed also once a week for 4 weeks. And then repeat cycles are dosed based on treatment response or based on, what patient and or clinician wants, but not sooner than 50 days. The data supporting efficacy for these drugs was based on the ADAPT trial, which really was what studied IV Vyvgart. And then there were other studies that showed that the serum levels for Vyvgart Hytrulo were similar to IV Vyvgart and thus supposedly has the same efficacy. This is data from the ADAPT trials, which involved 167 patients. Patients had to at least have an MG-ADL score of 5, which is where they rank their ocular, bulbar, respiratory, and extremity symptoms on a subjective scale. There were other scales, including the far right graph is an objective measurement, the QMG or quantitative myasthenia gravis score. And I don't know why this didn't print off, but each little tick at the bottom is weekly. And so the red line are the placebo groups and the blue line is the IV Vyvgart or Efgartigimod group. And so pretty quickly, even with the first week of dosing, there's a separation and there's improvement subjectively and objectively in people's myasthenia symptoms. And so that is sustained over several weeks of the dosing. And then as the medication wears off over several weeks, there's a gradual return to baseline, which is then in the trials when it would be redosed. In clinical practice, do we wait till someone wears off to redose them? Probably not. We probably try to give them, maybe do the average length of time between cycles, or if someone's more tenuous, do closer to a 50-day cycle length just to keep them from wearing off. But there is flexibility in this class of medications that you can have flexibility in dosing cycles. As far as side effects, they tend to be pretty mild. It's a pretty well tolerated medicine. Sometimes you may have headaches, some mild infections like URIs or UTIs. There can be hypersensitivity reactions, particularly to the subcutaneous form, the Vyvgart Hytrulo. But these all, my experience and in the trials, were pretty mild. I don't think anyone's ever stopped medication because of adverse effects. These medications are approved, well, IV Vyvgart is approved for acetylcholine receptor positive generalized myasthenia since 2021, and then Vyvgart Hytrulo was approved in summer last year. The studies involved seronegative patients, but it only got approval for acetylcholine receptor patients. And so technically, there's only FDA approval for these two medications for the acetylcholine receptor positive patients. However, we have another option in class, which is Rystiggo or Rosanolixizumab. This is an IgG4 monoclonal antibody that targets the Ig binding region of the neonatal receptor, which also leads to reduction in the IgG concentrations. The data for this was based on the Makarin trial, which involved 200 patients, looking at different treatment arms of different dosing, 7 versus 10 milligrams per kilogram. And pretty similar to the Vyvgart, the first scale or graph on the left is the MG-ADL or subjective scores. The myasthenia, other objective scales are to the right, and placebo is in blue, which is at the top, and the treatment arms are purple and green in these graphs. And so there's pretty quickly within first couple weeks, rapid improvement in patients' symptoms, subjectively and objectively, which are sustained for several weeks, just pretty similar to Vyvgart. So very quick onset, sustained efficacy till the medication wears off. Similar adverse effects, headaches, infections, sometimes hypersensitivity reactions. And of note, Rystiggo was approved for both acetylcholine receptor and MuSK positive generalized myasthenia patients. And so that would be probably the most unique item for this medication, is it was approved for MuSK, which is uncommon for a lot of these newer meds. So now we're getting to the complement C5 inhibitors, and basically these medications are blocking the complement system, which leads to destruction of the neuromuscular membrane. Important to know that these medications are associated with increased risk of meningitis or meningococcal infections, so they have to be vaccinated before getting these drugs. We used to at least give the initial doses and then wait 2 weeks before giving the meds. But most recently, the FDA requires us to fully vaccinate these patients before starting this class of medicine, or put them on prophylactic antibiotics, which would be penicillin or azithromycin if they had a penicillin allergy. And you have to give both the ACYW and mean serogroup vaccines for these drugs, which here we usually do Minveo and Bexsero. Because this act works on the complement system, these drugs are just used for the acetylcholine receptor positive patients. And these are the 3 currently approved drugs. And this is similar to some of our earlier slides of how the complement acetylcholine receptor antibody patients promote or activate the complement system, and that the acetylcholine receptor antibodies bind to the receptor, which then leads to formation of the C1 and complement activation, which leads to formation of the MAC or membrane attack complex, which leads to degradation of the postsynaptic membrane, which then leads to internalization of acetylcholine receptors and impaired muscle contraction. So same cascade I had shown earlier. And this is a more blown up view of how the C5 C5b and other complement proteins lead to formation of the membrane attack complex. Soliris or Eculizumab was the first of this medication to get approved, of this class to get approved actually in 2017. So it's been around for a while. It's a monoclonal antibody that binds to C5. It's dosed IV weekly for 4 weeks, and then maintenance dosing is every 2 weeks. The data that supports efficacy of this drug comes from the REGAIN trial, and their open label extensions as well. But this drug notably was studied in a more refractory population who were already requiring at least 2 immunosuppressants or other rescue IVIG or PLEX therapies, which is different than a lot of the other trials that looked at more mild generalized myasthenia patients. This is a more refractory group in the REGAIN trial. And so the initial trial did not show a significant change in the subjective MG-ADL scores, but there were improvements that were significant in some of the objective markers, like the QMG scale we use, from a 45 versus 19% improvement. There's a lower rate of myasthenia exacerbations in the group on Soliris that was maintained over 3 years. And over half of patients on this drug were able to achieve a minimal disease manifestation or pharmacological remission on this drug. And this is data from the REGAIN and the extension trials over years. The left side of the graphs are, the red is placebo, the blue is the drug Eculizumab or Soliris. And then where that dotted line is, that's where there was a crossover for the open label extension, and placebo was able to get treatment drug, which quickly matched. They all had similar efficacy once all the patients were on the study drug. Just like the FCRN blockers, Soliris has pretty quick onset action within weeks. It's sustained over years. And so pretty similar looking graph to what we'd seen before. And the top is the subjective scale MG-ADL, and the bottom is one of the objective markers scales or QMGs. Other side effects can include headache, sometimes musculoskeletal pain, or respiratory infections. And even though this was only approved for myasthenia in 2017, it's been on the market even longer for PNH since 2007. So it has a lot of safety data, which is different than the other class, which is more new. Ultomiris or Ravulizumab is another drug, complement inhibitor, also monoclonal antibody that binds to C5. It's dosed IV, and this is basically a longer acting form of Soliris. It can be dosed every 8 weeks. So much nicer dosing regimen for patients. Data was based, for efficacy was based on the Champion trial and extension data, which I think I have here. This looks like similar graphs. The red is the placebo, the blue is Ravulizumab or Ultomiris, that within first few weeks, there's significant improvement in patients' myasthenia, subjective and objective scores, which is sustained with repeat dosing of the drug. And side effects tend to be pretty mild, headaches, diarrhea, URI, pretty similar to Soliris, and actually not that different from placebo arms. And this was approved in April 2022 for acetylcholine receptor positive myasthenia. And this is a breakdown of how Soliris or Eculizumab is different from Ultomiris or Ravulizumab. And so at the top is Soliris or Eculizumab, where it binds to C5 in the bloodstream, then it's taken into the endothelial cell. And the Eculizumab stays tightly bound to C5, but it does not bind very well to the neonatal FCRN receptor. And thus, both the drug, Eculizumab, and the C5 complex get broken down by the lysosomes, so they're cleared out. And because it gets cleared out, that's why it has to be dosed frequently. It's not long-lasting. It's dosed every 2 weeks as the maintenance. Whereas the Ravulizumab or Ultomiris, which is the bottom, it was reformulated to have a better affinity to binding to the neonatal FCRN receptor. So it can get recycled, and it has less affinity to binding, but will release the C5 complement to where it will get broken down by the lysosome. And so it's just some remodeling of the drug for a longer lasting effect. It's also a reason why Ravulizumab cannot be given with the neonatal FCRN receptors, is because of how it works and how its long half-life is sustained, basically. And then the last drug that's currently approved in this class is Zilbrisk or Zilucoplan. It is not a monoclonal antibody. It's actually a small macrocyclic peptide, but also binds to C5. And it's dosed once a day, but can be self-administered as a subcutaneous injection. All the other medications have to be administered in an infusion center or by a healthcare professional, but this can be self-administered by patients. Data was based off the RAISE trial. And again, the left graph is MG-ADL or subjective scores, and the right graph is the QMG or objective scale. That there's quick separation within the first few weeks of getting med that's sustained with repeat or continued dosing. And side effects of Zilucoplan include injection site reactions or bruising, which is a little bit more than placebo, sometimes headaches, diarrhea, which tend to be pretty mild. And this was just approved several months ago in October. So this is very recent. So that's the overview of what's currently on the market. And the question is, when do we use these drugs for our patients? And, there's studies that, it's an art, I would say, in treating myasthenia, and you really have to balance trying to improve patients' clinical symptoms against the cost of the medication, side effects of medications, and the burden of treatment. This was some data recently published. It was survey data published in Muscle & Nerve, where they surveyed 81 neuromuscular specialists about their role of using these newer drugs, the FCRNs and complement inhibitors. And the azathioprine and mycophenolate mofetil, the oral non-steroid drugs, were usually used as first line for immunotherapy. Sometimes IVIG was used as a bridge or in patients where they couldn't use steroids initially. Rituximab was most commonly used in refractory cases. And these newer agents, the FCRN and complement inhibitors, were typically reserved more for bridge therapy. Mostly in this survey, it was because of cost and lack of experience with the drugs. And also concern potentially about safety profiles. With complement inhibitors, there's always this risk of meningitis, though there's been, with all the drugs for myasthenia, there's not actually been a case report of meningitis. And affordability is also a concern. But other pros are, these are very fast acting medications. I mean, I've shown you all these graphs, but if we overlap them, they would look pretty similar if we overlaid them. Both classes of medicines have quick onset within a few weeks that can be sustained. And then with repeat dosing of the drugs, it can be maintained. It would be a good role for not only bridge therapy, but also refractory patients. I think also for patients who would not respond well or have other contraindications to being on other drugs, traditional treatments. And this may be a pro and con, but these drugs come as IV or subcutaneous routes, which has pros and cons. Some patients hate injections, but some medications like Ultomiris, which is dosed once every 8 weeks, I find that very helpful for my patients who are non-compliant with oral meds, that I see them every 2 weeks in clinic. They get the drug that day. They're always being treated. And so it's a balance and an art to finding what works, I think, best for these patients. Cost. Before I throw up the cost, does anyone want to have like a guess of or estimate of what they think any of these agents would cost for one cycle or 1 year? For how much? For how long? For a year? 100 grand for 1 year from Dr. McKay. $500,000, Jared. A lot. I wrote this down because some of this is weight-based dosing, and this is data pulled from Up to Date, which is, I'm sure the cost of these medications is contracted out, and there's discounts given with insurance contracts or hospital contracts, but per Up to Date, without discounts, this is the cost of drugs, which is way more expensive than even what we used to do for IVIG or plasma exchange routinely. Yeah. Of all these, I probably would look at the yearly dose probably for best comparison. The least expensive is Ristigo, which is one of the FCRNs blockers, and the most expensive does look to be Soliris, but the others are kind of in between. They all 400, $500,000 if you were getting closely dosed cycles for everything. So extremely expensive. However, these patients, I think these medications have a role. And in general, the goal for treating myasthenia is to have minimal disease manifestation or minimal symptom expression is what may be used. And that's when they have, low scores on their MG-ADL, which is a subjective measure. And, I think they have better quality of life when they can reach this status. And, oh, good not yet. It really is an art to, I think, figure out what works best for our patients. I think we've tried, Dr. Alpers and I have patients on most of these therapies at some point, whether they are on them briefly or long-term. It kind of depends on their clinical situation. Trying to be stewards of healthcare and dollars and medicine, but also trying to do what's right for our patients because these medicines are very effective. They're quickly effective. They're very well tolerated. If cost wasn't an issue, I'd probably put everyone on them because they work very, very well. But obviously that cost is something to keep in mind. And that's actually something we're keeping in mind for a current inpatient we're trying to treat as a refractory myasthenic. The future of myasthenia treatments is rapidly expanding. This is some recent data pulled on drugs in clinical trials. There's more drugs in the complement inhibitor category and FCRN blockers. There's other classes of medications being studied that really work on targeting B and T cell proliferation and how that affects myasthenia. That has to do with the chemokine and cytokine pathways, affect both P and T cell pathways. There's also CAR T cell therapy, and these are all in different phases, as you can see here. And here's a diagram of different targets for these classes of medications, some of them kind of overlapping with what we've already talked about. So a lot of interesting medications on the market, which I'm hoping will drive competition for drugs and probably costs down as the market gets flooded with medications. But really an exciting time to treat myasthenics, that we have more options that are becoming available every year. There's another one just approved several months ago, which was Zilbrisk, and this is rapidly expanding. So you're going to be seeing, especially as the cost is driven down, a lot of patients on these meds. Hopefully we're keeping them out of the hospital, but you may see some come through who are in a crisis. I'm going to transition to research studies we have here or coming to Erlanger. One we are currently enrolling is a registry for myasthenia patients on complement inhibitor therapies. Dr. Alpers is the PI for the trial, and I'm the sub-I. And basically, we're just trying to collect real-world data on patients on these therapies about efficacy, safety, and patterns of drug utilization, how if patients on these drugs, how it affects their prednisone and other medication dosing, for example. And so we're actively enrolling for this, and those are patients we're identifying in clinic. And then we have our first drug trial coming, which will be for IV Vyvgart or efgartigimod. And this is particularly looking to recruit seronegative generalized myasthenic patients. And because IV Vyvgart is currently approved for acetylcholine receptor positive patients, labeling by the FDA, but not technically approved for seronegative. So this is the role of trial.
And this context, seronegative is also less common.
Yes. So they had to be negative for acetylcholine receptor antibodies, but they can have positive MuSK, positive LRP4, or be the traditional seronegative patients. They do have to be generalized. We're not recruiting ocular patients. And there's some other criteria about their prior dosing that we would go over if we were enrolling a patient. And so basically patients will be randomized to either drug arm or placebo for a cycle. And then there'll be crossover to where the placebo arm can be crossed over into receiving drug as well. And so not sure how long offhand we're going to be able to extend the open label period. Here we have it up to 104 weeks, but this is exciting to have this available to our patients, especially the seronegatives group. And so something to keep in mind that if cost is an issue, we're going to have some clinical trials here where patients will have some access to drug. And we're hoping, to continue building access to clinical trials here with our department too. Yeah, so here I threw it Dr. Albert since he's PI for trial, and I think I can speak for him that we both have a passion for treating myasthenia. We think these patients can generally do very well. We want the best for our patients. We want them to live very fulfilling lives outside the hospital, keep them away from the hospital. And just so you know, June is Myasthenia Gravis Awareness Month, so that's coming up. And I don't know if I mentioned it earlier, it is sometimes referred to as the snowflake disease. So if you see that in like marketing things, because every patient is unique, like a snowflake. So that hence the reference to snowflakes. All right, y'all have any questions? Mm-hmm.
It's because it's a well-defined disease with a very clear definition of what the disease is, and clearly defines outcome measures. So for all of the novel agents in the market, myasthenia is one of the first diseases that they look into. Yeah, it's not a history.
Yep. Yeah, and then other drugs like Ultomiris was just approved, I think, for NMO recently. So maybe first studied in myasthenia, but then has other indications like Efgartigimod or Vyvgart is now being studied in CIDP population. I actually have one patient off label on Vyvgart for that reason. Keep them on them. Keep them on steroids.
Chelsea, sorry, can you hear me?
So for those on Zoom, the question is, what do you do with these patients in the hospital who are treated with IVIG or Plex and you're trying to send them home, discharge them? What discharge medication regimen should they be on until outpatient follow-up? Yes, please keep them on their prednisone. And I would say even when they first come into the hospital, if you're starting your IVIG or Plex, bump their prednisone to an adequate dose. You know, some of this depends on comorbidities and age. I would say at least 10's a baby dose. I would probably say at least 20, even in an older person. Sometimes closer to 40 milligrams. I rarely go higher in a myasthenic, but I don't want them to bounce back to the hospital because they didn't have adequate prednisone dosing, and it will take a few weeks to kick in. And the IVIG or plasma exchange should bridge them until the prednisone is fully kicking in. So you're trying to, yeah. If they're intubated, throw it at them. Yes. If they're not intubated, be cautious because you may have paradoxical worsening with prednisones initially, and then they're going to get intubated. If they're already on it, I'd probably, especially if you're already starting other treatments, as long as they're not about to, you're trying to keep, they're not so tenuous from a respiratory standpoint, I would just increase their dose to an adequate dose. And then we can taper it as an outpatient. All the long-term effects of steroids, that's more for like high dose, long-term regimens, like short-term, 1 to 2 months, high dose steroids, like that's nothing in the grand scheme of things compared to the other adverse outcomes of myasthenia, I think. And as long as you tell us that, hey, this patient's in the hospital, we have ability to get them into to our clinics quickly to taper, or give them instructions on how to taper until they see us. Oh yeah, I would start it inpatient. Are you also treating with IVIG or Plex? Oh, then yeah, if they've got Plex on board and are improving, I would go ahead and start prednisone in that case. And if you're feeling a little cautious about someone's respiratory status, you could always kind of gradually up taper prednisone, maybe start at 20, then go up, after several days, go to 30 or 40. I mean, it's an art. There's no black and white criteria about prednisone dosing. There's been studies about starting high and then quickly tapering, or like gradually tapering up. And there's no clear like guidelines. It's just probably the most caution I would use in someone who's tenuous from a respiratory standpoint. It's just cautiously go up or wait till they've got a couple sessions of Plex or IVIG before starting it. I would say the trend is more important than the absolute. As long as the trend's improving from a NIF standpoint, that's the most reassuring. I have patients, I mean, I'm not doing NIFs in clinic. I'll do like a single breath count, like poor man's vital capacity. And I trend that over time. I have some patients who'll count to 15, which is terrible, but they always count to 15. Whereas I have some patient that counts to 40, but then the next time they're counting to 30, then counting to 20. That is the trend. In my opinion, that's more important. Same on the inpatient side. I may have to consult Dr. Alpers on this one. I mean, they're going to be intubated. And you're going to have them on treatment for several days. What, I mean, is that your practice now that you would normally do in the ICU?
It's always depend on what the patients. If it's more like an operative, those are the patients that can't be extubated afterwards, and then you find out, oh, wait, this is myasthenic. If it's in the context that they're having respiratory failure to myasthenic and need to be intubated, they're going to be intubated for several days and can't wear off. It doesn't really matter. You're going to be administering other things that are going to be
Yeah, we have general guidelines we give to patients who are having planned surgeries to like take them with their pre-op appointments. But I agree that in the acute crisis period, it's probably not going to make much of a difference. Which, yes.
If you go into the cost one real quick, I think this is interesting. So we discussed this, the Plus Blue Shield, and for their data, this is utilization and contractual and everything else. This is per month, the cheapest is Vyvgart by TrueLoad, which was $25,000 per month.
Sounds like they have a nice contract in place.
Sounds like they do, because also Vyvgart was just after that at $29,000 per month. The most expensive was Zilbrys at $50,000 a month, which pushed it to $600,000. Which means also, and Soliris is not on that list because Soliris, in their mind, is no longer a player since Ultomiris came to market.
Yeah.
But there's other contractual adjustments, and that's why, for example, we have Vyvgart on inpatient formulary because it is the one that we can actually get at a reasonable enough cost that we've been able to maneuver. Yeah,
pharmacy told me today inpatient Vyvgart dose would be $18,500 per dose.
Which is
Still very.
That's the Vyvgart.
Actually, that's more than what's up there. I don't know why our dose is higher.
Yeah, we should have a discount.
Yeah, we got charged more apparently. But the future, I think these prices will come down with competition. And so this is just in the past few years, most of these have come to market. So 5 years, this picture is going to dramatically change. I hope in 5 years we have a different graph for cost and treatment regimens.
Our patients don't pay for this.
Oh, that's true. Yeah, I mean, insurance companies have contracts to get certain drugs at lower costs. There are copay assistance programs for non-government insured patients. So like commercial insured patients, they have no copay. And then those who have Medicaid or Medicare, we have grants or foundation assistance programs that get drugs covered. So I only have had maybe one patient had to have some sort of copay because he didn't meet criteria for the assistance programs, but almost all of them will be covered currently. We're still trying to be good stewards of healthcare and dollars and treatment regimens. All right, that's all I have. Thank you, guys.
Last thing, I like the slide you have also that has